Hello everyone, I'm Captain Velasco and I'll be covering the topic on out-of-operating room anesthesia and sedation management. Here are the objectives for my presentation as outlined on our syllabus. First, I'm going to define monitored anesthesia care and conscious sedation. Next, I will define general anesthesia and the levels of sedation using the American Society of Anesthesiologists guidelines. I'm also going to summarize the standards for basic anesthetic monitoring in MAC, describe the use of MAC and conscious sedation outside of the OR by anesthesia providers, as well as talk about the application of the components of MAC and conscious sedation outside of the OR as used by anesthesia providers. First, I'm going to define sedation, which is the act of calming and depressing one's awareness to the environment. Analgesia is the relief of pain. Anesthesia, on the other hand, is making one insensible, which could either be a total or partial loss of sensation, whereas general anesthesia involves analgesia, amnesia, and immobilization. Therefore, sedation and anesthesia are two concepts at different points along a continuum. The movement along this continuum depends on several factors such as the nature of the procedure, medications used, the patient's condition such as his or her age and associated comorbidities, as well as the person's training in administering these medications. The term conscious sedation is often used by non-anesthesia providers who provide sedation in other settings outside of the operating room. Monitored anesthesia care, on the other hand, implies the potential for a deeper level of sedation, and it is always administered by an anesthesia provider. Monitored anesthesia care includes all aspects of anesthesia care, such as pre-procedure visit, intra-procedure care, and post-procedure anesthesia management. When providing monitored anesthesia care, one should be prepared and qualified to convert to general anesthesia when necessary. Here are the levels of sedation and analgesia as defined by the American Society of Anesthesiologists. First is minimal sedation, in which a patient receives a sedative which may impair his cognitive and motor function, but must still be able to respond normally to verbal commands and able to maintain normal ventilatory and cardiovascular function. Second is moderate sedation and analgesia, also called conscious sedation. In this stage, the patient has depressed level of consciousness, but is still able to respond purposely to verbal commands with or without tactile stimulation. The patient should be able to maintain his respiratory and cardiovascular function. In deep sedation and analgesia, at this point, the patient is not easily aroused, but still able to respond to repeated or painful stimulation. The patient's ventilatory function may be impaired, thereby requiring assistance to maintain a patent airway. The patient's cardiovascular function is still usually maintained at this point. General anesthesia, on the other hand, renders a patient unarousable to painful stimulation. Their ventilatory function is often impaired, requiring intervention in maintaining a patent airway. Positive pressure ventilation is often required. The patient's cardiovascular function may also be impaired. Here is a table summarizing the continuum of the depth of sedation from minimal sedation to general anesthesia. Non-operating room anesthesia refers to both inpatients and ambulatory surgery patients who undergo anesthesia in settings outside of a traditional operating room. It is estimated that non-operating room anesthesia accounts for 12.4% of all anesthetic care in the United States. Out-of-OR anesthesia requires the anesthesia provider to work in remote locations in the hospital, where ease of access to the patient and anesthesia equipment is compromised. Furthermore, the staff at these locations may be unfamiliar with the requirements for safe anesthetic delivery. It is important to remember that the same basic standards for anesthesia care need to be met regardless of the location. Here are the basic principles and considerations for providing anesthesia in settings outside the OR, which are broadly classified into three categories. First is patient factors, such as the patient's associated comorbidities, airway assessment, fasting status, and monitoring. Secondly, environmental issues must also be considered, such as the availability of anesthesia and emergency equipment. Magnetic and radiation hazards must also be evaluated. And lastly, procedure-related aspects must be taken into account, such as the duration, level of discomfort, patient position, and surgical support. The ASA closed claims database has demonstrated that claims related to out of the operating room anesthesia have a greater severity of injury than closed claims related to the operating room anesthesia care. Monitored anesthesia care was the primary technique in more than half of the claims reviewed. Here is a list of specific conditions that warrant special care when providing anesthesia or sedation outside of the operating room. Patients who are unable to cooperate, such as those with intellectual disability, severe gastroesophageal reflux, or medical conditions predisposing patients to reflux, such as gastroparesis secondary to diabetes mellitus, orthopnea, severe increased intracranial pressure, decreased level of consciousness, which depresses their protective airway reflexes, known difficult intubation, dental, oral, craniofacial, neck, or thoracic abnormalities, which would compromise the airway, presence of respiratory infection or unexplained fever, other comorbidities such as obstructive sleep apnea and morbid obesity, procedures which are lengthy, complex, and painful, as well as those that puts patients in uncomfortable or prone position, which can limit access to the airway, can also be problematic. Acute trauma and extremes of age are also factors warranting consideration. These conditions need great attention as they predispose the patient at a higher incidence of complications associated with sedation and analgesia. Here is a list of complications associated with sedation and analgesia: airway obstruction, aspiration, regurgitation, dental and soft tissue injury, respiratory depression, hypoxemia, hypercarbia, and apnea. Many of the closed claims are from injuries associated with inadequate oxygenation and ventilation during procedures in the GI suite. Hypotension, cardiac arrhythmias, deep level of sedation and unresponsiveness, undesirable patient movement, drug interaction, adverse reactions, and unanticipated admission. The anesthesia provider therefore must be trained and experienced in airway management and cardiopulmonary resuscitation, ensuring that needed resuscitation equipment and drugs are present and functional prior to the procedure. The anesthesia provider must be vigilant and dedicated to the continuous monitoring of the patient's physiologic parameters. Let's now discuss the monitoring standards for providing monitored anesthesia care, whether it is in the operating room or any other settings. The standards set by the American Society of Anesthesiologists for monitored anesthesia care are applicable to all levels of anesthesia, which means that the expectation for out of operating room are the same as in any practice locations, keeping in mind that our main goal is patient safety while minimizing physical discomfort and pain and allowing controlled movement for the performance of the procedure, as well as the return of patient status that is safe for discharge. First, a qualified anesthesia provider must be present. A vigilant and well-trained anesthesia provider is the single most important monitor. Patients presenting for sedation and analgesia should undergo a focused physical examination, including vital signs, auscultation of the heart and lungs, and evaluation of the airway. Pre-procedural laboratory and diagnostic testing should be guided by the patient's underlying medical condition. During all anesthetics, the use of quantitative method of assessing oxygenation, such as pulse oximetry, is specifically mandated by the ASA standards for intraoperative monitoring. At the very least, patients must be assessed for qualified signs of ventilation, such as observed chest excursion or auscultation of breath sounds. Capnography is most effective in the intubated patient, but side stream capnographs have been adapted to use with face mask and nasal cannula. At a minimum, the electrocardiogram must be continuously displayed throughout the anesthetic with the blood pressure and heart rate evaluated at least every 5 minutes. When clinically significant changes in body temperature are intended, anticipated, or suspected, body temperature monitoring must be used in order to facilitate the maintenance of normothermia. Bispectral index monitoring, although not a standard, may be used as an adjunct in evaluating a patient's response during drug-induced anesthesia and sedation. The absence of recall is associated with the values below 80. Monitored anesthesia care is often provided in the context of regional and local anesthetic techniques. Therefore, it is vital that the anesthesia provider must be prepared to recognize and treat local anesthetic toxicity. A variety of medications are commonly administered during monitored anesthesia care, with the desired endpoints being patient comfort, maintenance of cardiorespiratory stability, improving operating conditions, and preventing recall of unpleasant perioperative events. Specific drugs used for monitored anesthesia care includes, but are not limited to, propofol, benzodiazepines such as midazolam, opioids such as fentanyl, remifentanil, and alfentanil, ketamine, and dexmedetomidine. The ability to predict the effects of these drugs in our armamentarium will allow us to deliver adequate sedation while maintaining our patient's cardiorespiratory function. As a general principle, to avoid excessive levels of sedation, drugs should be titrated in small increments or by adjustable infusion rather than administered in larger doses, according to the predetermined notions of efficacy. Scoring systems have been devised to facilitate timely and safe discharge from the post-anesthesia care unit, such as the Aldrete scoring system, which includes activity, respiratory, circulation, consciousness, and oxygen saturation. Here, however, is a generic guideline for safe discharge, keeping in mind that the patient must be discharged by both the person who administered the anesthesia and the person who performed the surgery. Vital signs must have been stable for at least 1 hour. The person must be oriented to person, place, and time, able to retain orally administered fluids, able to void, able to dress, able to walk without assistance. The patient must not have more than minimal nausea and vomiting, excessive pain and bleeding. Written instructions for the post-operative period at home, including a contact place and person. The patient must have a responsible adult escort them home and stay with them at home. During transport, airway management equipment including a face mask and an ambu bag or a Jackson wrist circuit should be immediately available for providing positive pressure ventilation. Equipment for continuous monitoring of the patient's physiologic status, as well as medications to maintain intravenous regimen and emergency drugs must be available. Depending on the patient's condition, additional equipment may be necessary for transport. In order to safely deliver anesthesia, the ASA guidelines has a list of expectations for out of the operating room anesthesia. And this includes having a reliable oxygen source with backup, such as the green oxygen e-cylinder, suction, if inhalational anesthetics are to be used, an anesthesia machine with a scavenging capability must be available. Adequate monitoring equipment for the intended anesthetic as well as for transport if necessary. Safe and sufficient electrical outlets, adequate illumination with battery backup, sufficient space, an emergency cart with a defibrillator, drugs, and other equipment to provide cardiopulmonary support. A self-inflating hand resuscitator or ambu bag should also be available. A reliable means of two-way communication to request assistance when needed is also vital. Safety codes for the facility must be met, and an appropriate post-anesthesia management must be available.